Well, good afternoon, everyone, and thank you so much for joining us today. My name is Tiffany Rubalcaba. I am the Associate Director of E-Learning with the California Primary Care Association. And on behalf of CPCA, we want to welcome you to today's webinar. And this is the Introduction to Eating Disorders. This is the first in our 4-part webinar series that's brought to you in part by Partnership Health Plan of California and the National Center of Excellence for Eating Disorders. So before we get started and I turn things over to our speakers today, I just want to go over a couple of announcements to make our time together more successful. You may have noticed that attendee phone lines are currently muted, and they will remain muted throughout our presentation today. So at any point, if you have questions or comments during the presentation, you can click that small radial button with the hand icon. And when we break for Q&A, I will open up individual phone line and let you know when you have full connection so you can present your questions or speak directly with our panelists. Additionally, you can use that questions module that's in the webinar toolbox on the right side of your screen. You can chat in your questions at any time, and I will then present your question on your behalf. Again, when we break for Q&A, I'll present those in the order they are received. You can also use this same question box to communicate with me if you have any technical issues or any questions related to CPCA's other offerings, and I will chat directly back to you. So please monitor that chat box throughout our session today. We did email a PDF copy of the slides to you all about an hour ago. If you did not receive those, you can download them in the handouts module, also on the right side of your screen there. You can download those at any time during our presentation today, and they will be included in the follow-up email that we'll send later this afternoon that will have a copy of this recorded session and, again, a copy of these slides. So we want to thank you for registering for today's webinar. We encourage you to visit our website at cpca.org to register for future trainings and events, including our Quality Care Conference that's coming up next month. So with that, I'm going to turn things over to our speakers today. Joining us is Anna Bardone-Cohn. She is Director of Clinical with the University of North Carolina at Chapel Hill. And joining her is Dr. Louise Metz. She's an internal medicine physician with the Mosaic Comprehensive Care. So ladies, I'm going to turn my camera off, saying goodbye to everyone, and I am going to pass presenter control to you now. So please click that button to allow access to share your screen with us. And remember, you are muted. Perfect. We see your slides.
You do? Okay.
Yes.
So we are not seeing our slides on my screen. Let's see.
Oh. If you just, are you in your PowerPoint presentation now? You're not seeing your PowerPoint?
Just see ourselves right now.
Oh, if you want to close that box on your webcam, you can do that. If that's a distraction or if that's covering up your screen.
Perfect.
Okay.
Okay. Well, thank you. Thank you, Tiffany, for the introduction. We're very happy to be here. I'm Louise Metz. I'm an internist and the owner of Mosaic Comprehensive Care in Chapel Hill, North Carolina. We provide primary care for adolescents and adults and have expertise in the assessment and management of eating disorders. We also focus on weight-inclusive care and gender-inclusive care at our practice. I've worked in the field of eating disorders for about 12 years now, and I found it a very rewarding field to work in. It's really very rewarding to provide care for individuals who experience these often underdiagnosed and undertreated conditions. And I've really enjoyed the collaboration that is a central part of this work.
Great, and I'm Anna Bardone-Cohn. I'm delighted to be here and working with Louise to present this to you. So I'm a professor at the University of North Carolina at Chapel Hill in the Department of Psychology, and I'm a clinical psychologist. My focus has been in eating disorders through the end of graduate school, so since graduate school, about 20 years now. My research focus is more on the psychosocial factors, so I'm interested in things like personality, social factors, family, peers, race, ethnicity, and also I do research on recovery from eating disorders and how do we find that and how do we hopefully get more people there. And yeah, so that's a little bit about me.
Okay. All right, great. We're going to get started.
Okay, great. So here's our title. So Eating Disorders 101. And I wanted to say that this is, let's see. Just gonna, we're just making sure we can get to the next slide.
Looks like we have a little bit of a technical difficulty here. Sorry about that. We're having a little bit of trouble scrolling through our slides.
Okay. Is there, if you kind of hover in the lower left corner, sometimes you see like a transparent control box? Yes, there you go. You could click that right arrow and yep, that second button, that will advance it. There you go.
Okay, we'll do that.
Great. That works. Thank you.
Okay, so this is coming from the National Center of Excellence for Eating Disorders, established with a SAMHSA grant to Dr. Christine Pete. And the mission, the key mission, as you see on the slide, is education and training. And so this is both for healthcare professionals like yourselves and also public stakeholders. So this would be people who have eating disorders, friends and families of those with eating disorders. And the website is at the bottom there, and we'll show you a screenshot on the next slide. But web-based platform, lots of resources. We encourage you to, sign up. So if you go to that website, you can click on I'm a health professional, and it'll give you information and allow you to sign up for additional information. All right, so our goals, we'll go through the goals, and then after that, Tiffany, it'd be great to pull up the poll question. So we want to describe eating disorder diagnoses, and that'll be with the DSM-5. Talk about evidence-based screening measures for eating disorders. Review evidence-based practices for an initial medical workup. So if you get a positive screen, what are the next steps? And then recommend ways to approach patients that you do have concerns about and provide referrals. So if we could do that poll question now, that would be great.
All right, yes, let's get that up for everyone. So that first poll question is up on your screen. How much experience do you have in the diagnosis and treatment of patients with eating disorders? Go ahead and click in the bubble that correlates with your response and submit that response there. If you have exited from the webinar, toggled out of the webinar program, you can come back in by clicking that blue daisy on the bottom of your taskbar so that you can also participate in the poll. So we've had about 80% participation now, so I'm going to leave that poll open just a couple more seconds. All right, we're going to close in 3, 2, and 1. So we had 84% audience participation, and I'm going to share those results with everyone. And I'll read the responses back for anyone who's on an audio-only connection. So those that responded, 19% say they have no experience diagnosing and treating patients with eating disorders. 43% is our largest group there with very little experience. 36% with some experience, and only 1% with extensive experience.
Okay, that's very helpful. Thank you for completing that. So if you combine the no experience and little experience, it looks like we're thinking about, 63%. So clearly the majority don't have a lot of experience. We're delighted that you're here to find out more. So we're excited to go through that with you. All right. Here we go. All right, so we'll start with the diagnostic criteria. So what we have here is the diagnostic criteria pulled from the DSM-5, but we're going to provide some elaboration. So for anorexia nervosa, the first one there is restricted dietary intake, leading to significantly low weight for age, height, sex, and developmental trajectory. In the past, there's been a number that's been used as a guideline, like maybe less than 85% ideal body weight. That is still used often in research because you want a little more consistency, but importantly for clinicians, that was been removed because we want clinicians to have more freedom to decide what is significantly low and take into consideration, again, these items and also look at weight growth charts, which will be discussed a little later. The second point is intense fear of gaining weight or becoming fat despite low weight. And the way I talk about this when I introduce it and I'm teaching eating disorders is this is definitely more than, oh, I don't want to gain weight. I mean, this is a much stronger visceral reaction to gaining weight. We added in the DSM-5 the part in parentheses, so that wasn't there before, because researchers were finding that there were people who met all the other criteria for anorexia nervosa, but they just didn't resonate with the idea of fear. However, their behavior suggested they were really driven, probably by fear, to not gain weight. For example, someone who would say, well, I don't feel fearful about gaining weight, and yet I exercise 4 hours a day, to just be a little extreme there. So they were engaging in a behavior that interfered with weight gain, and that can allow you now to meet this criterion. And then the last one, they're ORs, so you can meet any of these and meet this last criterion, but a lot of people with anorexia meet multiple ones. So disturbed body perception, so this would be in its broadest, feeling that you are fat or overweight when objectively anyone who saw you would say, you know, you're very, very thin. The self-evaluation being overly due to weight and shape. A common way that that's assessed clinically or research-wise might be to ask individuals, if you think about all the different things that go into how you feel about yourself and your sense of self-worth. So this could be like yourself as a student or an employee, yourself as a parent or a child or a friend, or your appearance. Does weight and shape, is that the main aspect that influences how you feel about yourself, or one of the main ones? And that's what we're looking for here. Someone who either says, oh yeah, I wake up in the morning and if I get on the scale and I'm this weight or lower, I feel good going forward in the day. If I'm this weight or higher, I feel terrible about myself. So that's sort of the way we think about that. And then lastly, persistent lack of recognition of seriousness of low weight. So this would be, you know, they've heard from doctors or family that this is a concern, and they are maybe disagree or dismiss it. One item that's not here, we discussed later, but used to be here, so those of you who have done some of this may have heard this before, is amenorrhea. So a criterion used to be 3 consecutive months at least of no period. That was dropped for various reasons. One, it doesn't affect certain populations, doesn't affect males, postmenopausal or prepubertal females. It's kind of an issue when people are on oral contraceptives. And then also we found that whether you met the amenorrhea criterion or not, kind of severity and outcome were the same. So that's still a very relevant factor to look at, it's just not part of the diagnostic criteria. And then at the bottom there, we have the 2 subtypes, restricting and binge eating purging. So people would be diagnosed with one of the 2. Binge eating purging means, in addition to all those criteria, they are regularly engaging in binge eating and or purging. Purging would be things like vomiting and laxative use. Regular is usually defined as maybe weekly. Restricting would be, you know, restricted intake, maybe excessive exercise, but they're not regularly engaging in binge eating or purging. So I'm going to switch now to bulimia nervosa. The key behavioral diagnostic criterion there is recurrent episodes of objective binge eating and inappropriate compensatory behaviors intended to prevent the weight gain. And we'll elaborate more on those on the next slide. Frequency-wise, on average, we're looking at once a week for 3 months. This used to be twice a week for 3 months. This also switched with DSM-5 because we found that once a week or twice a week really didn't result in different outcomes and or different patterns of comorbidity. So it made sense to relax that frequency a bit. Like with anorexia, self-evaluation is overly due to weight and shape. And it must not occur solely in the context of anorexia. So you may wonder, wait, there is this binge purge subtype for anorexia. You know, how do you make that distinction? You cannot get a diagnosis of both anorexia and bulimia. If you meet all the criteria for anorexia and you're binging and purging, you know, at least once a week for 3 months, you are going to get the anorexia binge purge diagnosis. And that's because that was generally the more medically concerning one. And so we need to make sure that we tag those individuals with anorexia just to help determine kind of treatment that we need to be considering for them. We have here at the bottom a video clip, and this is of a woman speaking about her experience with bulimia nervosa. We thought it was quite good, but we also realized we didn't have time for it. So we leave it here for you all to view and think you might find it illuminating. Okay, so to elaborate on the behaviors, when we talk about a binge, and this is an objective binge, one of the factors, one of the key components is a sense of lack of control over eating during the episode. And so this would be, people might describe it as I couldn't have prevented myself from eating, or once I started, I couldn't have stopped. People sometimes describe it like as a ball rolling down the hill. It's just kind of then out of your control. So that's one piece of it. Another piece for bulimia is an unusually large amount of food. Now, this can get a little fuzzy. I mean, there are unusually large amounts of food that really everyone would agree that is just a lot of food, but there's some gray areas. So that can be a little tricky to figure out. One thing I want to note is that this is unusually large in context. So if someone said, oh, I ate a ton of food, and it was Thanksgiving, and I had, 2 pieces of pie, and I went back for extra mashed potatoes, and so on and so forth. If it's kind of what the family is doing at Thanksgiving, that might not be a binge. It could, but context is a little different there. There is something called subjective binge eating. We won't be talking about it here, but it's also concerning. It's loss of control, but not an unusually large amount of food. But for bulimia, it has to be an unusually large amount. And then lastly, a discrete period of time. We usually use a guideline of within 2 hours. And the main point here, it's not like a lot of food across the day like grazing. It's not like at start of every hour I ate, a decent bit, but not so much. This has to be a more compact period of time. And compensatory behaviors, the key examples there are self-induced vomiting, laxatives, diuretics. Those are all examples of purging. But then also we have non-purging compensatory behaviors, which are fasting, so maybe 24 hours without eating, or excessive exercise. That also is a little trickier to assess, what exactly is excessive. Often we do look at amount, but you also want to look at a sense of approach to it, like really hard-driven exercise to undo eating. People with this kind of excessive exercise might say, even if I'm injured or sick, I still, exercise hard to try to undo the effects of eating. Then binge eating disorder, you can basically think of it as sort of bulimia nervosa without the compensatory behavior. So there are recurrent episodes of objective binge eating, same frequency, at least once a week for 3 months, but there has to be an absence of regular inappropriate compensatory behaviors. Doesn't mean there have to be none, but say, for example, someone is binge eating at least once a week, and maybe a few times a year they make themselves throw up. They would still likely get binge eating disorder. That would be a better fit. I won't read the other ones, the last one, but there you have to meet 3 or more of the following regarding the eating experience. Okay, we're going to talk about 2 more eating disorders, but first we wanted to share this sort of overview, and this is on the eating disorders that have had the most research done on them. So in terms of prevalence, and actually I wanted to, well, I'll say this at the end here. In terms of prevalence, lifetime prevalence is least common for anorexia, and then bulimia nervosa, and then binge eating disorder. When you think about subthreshold levels, not surprisingly, these numbers get quite a bit higher, but this is for meeting the full diagnostic criteria. One thing before I go on to the others, I want to mention 2 things. One is that weight, by definition in anorexia is going to be very underweight. Individuals with bulimia nervosa often are in the average weight range, so it's nothing visually that you normally identify from someone with bulimia nervosa. And then binge eating disorder tend to be overweight or possibly obese. The other thing I wanted to mention is diagnostic migration. So it's not uncommon for individuals to start out with one type of eating disorder and then across time move to another one. A very common trajectory is from binge purge anorexia to bulimia nervosa. So I just want to mention those 2 things. In terms of age of onset, so it's adolescence through young adulthood, and you see the differences across these different eating disorders. Not to say that it can't onset later. There definitely are cases of middle age, for example, onset, but it's also probably more typical, most typical, that they've had an eating disorder before, had subthreshold levels, at a younger age. In terms of gender, it's absolutely true that certainly for anorexia and bulimia, also for binge eating disorder, females are affected more than males, but our understanding has changed in terms of how dramatic that difference is. So, for example, we used to think that maybe 90% of people with eating disorders had anorexia and bulimia were female. More current data suggests that actually might be between 67 and 83% of those with eating disorders are females. So we're now understanding that men experience this more than we thought. And certainly for binge eating disorder, that's pretty balanced. Data usually suggests about 60% of those with binge eating disorder are females, 40% are males. Comorbidity, I'll just let you look at those there. There's a bunch of different things. Comorbidity with eating disorders is more the rule than the exception. In terms of trauma in particular. That's across the board, but for anorexia, especially for binge purge subtype. And just a couple of comments there. One is that is considered a non-specific risk factor, which means trauma experience increases your risk for psychopathology in general. So it's not just eating disorders, but it does suggest something to kind of, be attentive to. The other thing I'll mention is that anxiety tends to precede the development of eating disorder, and depression tends to be subsequent to it. Doesn't always occur that way, but sometimes when the eating disorder has been resolved, the depression is resolved with it. And then lastly, in terms of race and ethnicity, my broad comment here is that prevalence rates really have been found to be very similar across African American, most research is on females, so I'll say Latinas, Asian Americans, and non-Latina Caucasians. Maybe for anorexia, we see African Americans having a slightly lower rate of anorexia, again, but generally you want to think of it as pretty comparable. All right, this I'll go through pretty briefly. This is called ARFID. It's new for DSM-5. It's eating disturbance, and you can see some of the criteria there: weight loss, nutritional deficiency, relying on tube feeding or oral supplements. But unlike anorexia, there's no significant distress about weight and shape. It's also not explained by lack of available food, so it's not that someone doesn't have access to food and thus they're not able to eat and lose weight, and etc. And it's most commonly develops in infancy and childhood, but it can persist into adulthood. And then lastly, in terms of the eating disorders, it's called OSFED. It's sort of a catch-all category, but with some structure. So the most probably common ones, or some of the most common ones here, are basically sub-threshold levels of anorexia nervosa and bulimia nervosa and binge eating disorder. For anorexia, the way that looks is usually all criteria are met, but even though they have had a lot of weight loss, they're not underweight. So this would be a case where someone, for example, in the last couple months dropped 20, 30 pounds. But their average weight. And what's great, I think, about this is that this catches someone before they get to such a very low weight, when we know it is much harder to treat them. So this is a nice way to hopefully catch a trajectory before it gets too far. With bulimia and binge eating, it could be lower frequency. So maybe they're doing this 3 times a month. So not quite the 1 time a week, or limited duration. Maybe they've been doing the binging and purging 1 time a week for 2 months. You don't have to say, well, check back in a month, let's see if you're still doing this. They can get a diagnosis of OSFED. And then purging disorder reflects recurrent purging behavior. So remember, that's things like vomiting, laxative diuretics are the most common ones to influence weight and shape, but this is in the absence of binge eating. So this is, not separate from bulimia. And also it's something, if someone has all the criteria for anorexia and they're purging, they would get the binge purge subtype of anorexia. So this would be not extremely low weight and not in conjunction with binge eating. Warning signs and symptoms. I'm not going to go through this in detail, but we put this up here because we thought, you may not observe this yourself, but these are questions that you might want to ask family, partners, parents, if they see any of these items in their loved ones. So I know some of these people are doing this in audio, so I'll just briefly say preoccupation with food, eating, and calories. For example, cooking a lot, but refusing to eat. Reluctance to eat with others. So they might say, oh, I've already eaten, and that could be sort of a way to get out of, eating situations. Food rituals, a very common one is cutting food into small pieces. Secretive behavior related to eating. So this could be finding that food is missing from the pantry from someone who maybe is engaging in binges, which are usually done secretively, or regularly using the bathroom shortly after eating as a way to vomit. So those are kind of things to look out for. And then lastly, weight and shape concerns. Of course, overvaluation is a diagnostic criteria for anorexia and bulimia, but this could be frequent self-weighing, a lot of body checking behaviors, wearing baggy clothes are some examples of that. All right, so in terms of what do eating disorders look like, we thought we'd have this slide to make a couple of points. One is that eating pathology is on a spectrum. So we talked about actual diagnostic criteria, but there's a continuum certainly, and that eating disorder stereotypes are misleading. So often we think about, white females, middle upper class having eating disorders, and that's concerning if we only focus on that. So very briefly, I just want to highlight males and males with certain athletic endeavors like wrestlers, for example, but definitely, don't forget the males, very important to assess them. Racial ethnic minorities, And a brief comment there is that there's, to tie in with trauma, there's some research that brings in the strong Black woman ideology, which is, the idea of being a superwoman and being able to do things independently and help others. There's data showing that trauma experiences by Black women can lead to them internalizing that more, and then having kind of emotion regulation difficulties and binge eating. So that's something that we see. Individuals with low SES, so living with food insecurity, there's been research showing that those with the highest level of food insecurity, in this case it was adults who reported having hungry kids in the home, had the highest levels of overall eating pathology and binge eating and weight self-stigma. So it's definitely a population to look for. We recommend you look at this video clip. It's a nice kind of expression of these different voices. And the last point here is that we know that there are these stereotypes, it could be explicit, but certainly implicit. And there's been research with clinicians, for example, finding that given the same passage with eating disorder symptoms, they are much more likely to recognize that as an eating disorder concern in Caucasian women and actually in Latina women, and much less likely to recognize the exact same symptoms in African Americans. So something to be mindful of. Here, I'll put this up to show you that basically we think about eating disorders from biological, psychological, and social perspectives. They're all important. Genetics has a role. It's not deterministic at all. And I think I'll leave it at that and move on so we can make sure we get to the other pieces. But this is a nice overview and a way of thinking about its complexity.
Okay, great. So now we're going to move on and talk about evidence-based screening measures for eating disorders. And Tiffany, if you could go ahead and put up that second poll question for us.
Yep, I will get that launched right now. All right, so for folks that are joining us, this second poll question, are you currently screening your patients for eating disorders? Your options are yes, I screen all my patients, or yes, I screen some of my patients, or no, I do not currently screen for eating disorders. So we have about half of the audience have participated in the poll. We're going to leave that open for a couple more seconds. Again, if you've toggled out of our webinar, please join us by clicking that blue daisy icon in your taskbar. And we're at about 75%, so I'm going to leave that open for about 3 more seconds. Okay, looks like folks are still responding.
Okay.
All right, we're going to close that poll now. We had 80% of the audience participate, and 14% indicated they screened all their patients, 34% indicated they screened some of their patients, and the largest majority, 51%, do not currently screen for eating disorders. So thank you.
Great, thank you. That's very helpful information, and we're hoping that one of the things you might take away from this is a change in your clinical practice to consider more routine screening. So we're going to talk a little bit more in detail about that. So for eating disorders, early detection is key. So patients rarely present directly for eating disorders care. Primary care is often the first point of contact with healthcare for an individual with an eating disorder, but they are usually not coming into their primary care provider saying they need help for the eating disorder. They are instead often presenting with symptoms that may be complications of their eating disorder, or they may not disclose any symptoms or behaviors. However, we know that patients with eating disorders have a high rate of healthcare utilization despite not directly seeking help for their eating disorder. And there are many reasons for that. So patients with eating disorders may be secretive, they may be ambivalent about getting help, they may be in denial about their eating disorder or not have an understanding of the fact that they may have an eating disorder, and they may be ashamed of their behaviors given the stigma attached to these disorders. There was one study actually that found that among college-age individuals, they found that only 20% of those who screened positive had ever received treatment. So we see here that there's a really important opportunity for us to be screening in the primary care setting for these conditions. And it's really a unique opportunity because we can leverage the existing relationship that we have with our patients and hopefully screen in a non-judgmental way, just like we would screen for, say, high blood pressure or thyroid disease or depression, and hopefully give patients the opportunity to open up to us. We also know that early diagnosis and treatment is very important because it leads to a better prognosis. So there are higher rates of recovery if patients are diagnosed and treated early on in the course of their illness. And we also know that delayed diagnosis leads to an increase in medical complications. And so again, screening is extremely important and something that can be easily done in the primary care setting. So now we're going to delve into some of the screening tools that are available. So there are 3 validated screening tools for use in the primary care setting. And then there is a screening tool that we'll show you that's online, that's self-administered. And the goal here is to have screening tools that have a high sensitivity to capture the very broad spectrum of eating disorder thoughts and behaviors that exist. So we're looking to make sure we are screening for the risk of anorexia, bulimia, binge eating disorder, and then potentially even subclinical eating disorder behaviors that do not yet meet the criteria for an eating disorder, with a goal again for early intervention. So we're going to talk about these in a little bit more detail. So the first screening questionnaire that's been validated for primary care is called the SCOFF, and it originated in the UK, and you will see that they use a term that we're not as familiar with in reference to weight in this screen, but it is a highly accurate screening tool. So the 5 questions on the SCOFF include: do you make yourself sick because you feel uncomfortably full? Do you worry that you have lost control over how much you eat? Have you recently lost more than 1 stone, which is equivalent to 14 pounds in a 3-month period? Do you believe yourself to be fat when others say you are too thin? And would you say that food dominates your life? So 2 or more yes responses is a positive screen. And studies have shown a fairly high sensitivity of 86% for all eating disorders with this screen, and a specificity of 83%. One other important point to note, however, is that if you look at a breakdown of different eating disorders, the SCOFF has a lower sensitivity for binge eating disorder. It has about a 69% sensitivity for binge eating, while it has a higher sensitivity for other eating disorders. Next, we have the eating disorder screen for primary care. This is a screen that I use in my practice, in my primary care practice. So it has 5 questions as well. The first question here is what we call reverse scored, meaning an answer of no is abnormal, whereas an answer of yes to the other 4 is abnormal. So are you satisfied with your eating patterns? Do you ever eat in secret? Does your weight affect the way you feel about yourself? Have any members of your family had an eating disorder? And do you currently suffer with, or have you ever suffered in the past with, an eating disorder? So 2 abnormal responses is a positive screen, and you can see here that it has a high sensitivity of 97% for all eating disorders. But again, if we look at a breakdown of this screening tool, we find that it has a lower sensitivity for anorexia, about 67%, compared with very high sensitivities for bulimia and binge eating at 100% for both of those conditions. And then lastly, the third validated primary care screen, which is the newest one, is called the Screen for Disordered Eating. It includes a few of the questions from the other screening tools that we just looked at, and then a couple other questions from other psychiatric questionnaires. So I'm not going to go through all of these, but again, 5 questions, 2 positive responses is abnormal, and the sensitivity here for all eating disorders is 91%. And then important to look again at the breakdown for other eating disorders. And what we see here with this screening tool is that across the board, it seems to have the highest sensitivity for anorexia nervosa, bulimia nervosa, and binge eating disorder compared with the other screens. So this is a newer screening tool, and I may actually begin to use this in my clinic kind of based on these new numbers that show it does have a higher sensitivity. And then lastly, we're going to look at the NECA Screen. So the National Eating Disorders Association has a great online tool. And this is one that is self-administered by individuals, and it might be useful to recommend to patients who may not be comfortable discussing their behaviors with you in the office yet, or who have some trouble understanding that they might have an eating disorder. It's based on the Stanford Washington University Eating Disorder Screen and consists of about 25 questions. And I'm going to see if I can link directly to it just to show you a few of the questions here. Okay, so it's right here on the NECA website. There's a link on the home page to the screening tool that you can see. And I'm just going to start it by answering a few of the questions with random answers to give you a sense of this tool. But you can see here this question: how much more or less do you feel you worry about your weight and body shape than other people your age? How afraid are you of gaining 3 pounds? When was the last time you went on a diet? So it goes through quite a few questions about behaviors and thoughts. It also has some questions about suicidality and some demographic questions. And then what's very useful is that at the end of the tool, it will give the individual an assessment of their risk. So this is an example here of someone who may be at risk based on the answers to their questions. And it encourages them to seek help, and then also gives them links to finding a treatment professional, as well as the number for the NECA helpline and a click for a chat function. So this is something that may be really useful to recommend to your patients. Okay, oh, and then lastly, the sensitivity for all eating disorders for this screening tool is about 80% based on the studies that we have. Okay, so who should be screened? So we recommend that all adolescents and adults are screened for eating disorders as part of their new patient visits and their annual physicals. This can be done very easily on new patient paperwork and annual physical paperwork. So you can choose one of these very easy screening tools to add to your paperwork, or it could be incorporated into your health record system. That being said, in particular, there are populations that we would highly recommend be screened, including those listed here. So adolescents, of course, are at higher risk. And again, we want to recognize those eating disorders early on and intervene. Athletes who may have pressure to be a particular size or body type, or pressure to eat in a certain way, should be screened. Oftentimes they are unintentionally under fueling their exercise, and we really need to be looking for eating disorders in that group. Those with a family history and those with a trauma history, which we touched on earlier. And then really key here is screening patients who are seeking help for weight loss or who have a history of chronic dieting. So we know that dieting is a risk factor for eating disorders, and one of the highest risk factors among adolescents in particular. And people who come in talking about dieting may actually, if you delve further, be exhibiting some true disordered eating behaviors. And we also know that dieting and restricting is something that can lead to binge eating. In addition, there are people with certain health conditions who we recommend should be screened. So these are medical conditions that are either associated with a higher risk of eating disorders or medical conditions that could be caused by eating disorder. So folks with diabetes are at higher risk, as are those with PCOS. People with irritable bowel syndrome, chronic constipation, or other GI conditions are at higher risk, and eating disorders can cause some of the symptoms of these GI conditions. Hypothalamic amenorrhea, so lack of periods, can be caused by malnutrition. POTS is a condition in which individuals have dizziness or racing heart when they stand up, which sometimes can either be associated with or caused by malnutrition. And then lastly, autoimmune conditions are associated with eating disorders. And then again, patients with psychiatric comorbidities should also be screened. Okay, so moving on to talk a little bit about the initial medical workup following a positive screen. So what are we going to do next once someone has screened positive? So we'll try to give you an overview here. I think there will be more details in future webinars, but we wanted to give you a sense of what that medical workup looks like and some of the things to be looking for. So first, just a couple slides about some of the common symptoms and medical complications. So these are some of the things that you may commonly see in primary care that should either raise a red flag that someone might have an eating disorder, or things that you should ask about in someone who has screened positive. So fatigue is a common symptom. Temperature dysregulation can occur, so cold or heat intolerance. Cardiovascular symptoms are common: dizziness, fainting, abnormal heart rate, swelling in the legs. And then endocrine symptoms, we've touched on this a bit, but amenorrhea, so lack of periods or irregular periods, infertility. And then another big one is stress fractures. So if an individual comes in with a stress fracture, they should definitely be screened for an eating disorder due to that risk of osteopenia or osteoporosis. And then GI complaints, again, are very common. And then there are multiple lab abnormalities that could raise a red flag, or things that you should look for in those who have screened positive. So hematologic abnormalities, definitely electrolyte problems, vitamin deficiencies, and there can be some cognitive symptoms that can occur. So some subtle memory symptoms, trouble with concentration. And really the key here is to note that complications of eating disorders affect all organ systems. Okay, so we're going to talk a little bit about vital signs and things that we're looking for in the physical assessment. So first, to talk about weight and eating disorder presentation. Some patients may have fluctuations in their weight when they present with an eating disorder. Some may have weight gain, some may have weight loss. Others may not have had any change in their weight but still have a significant eating disorder. And then the other thing that may be a new concept for some of you is the idea of weight suppression. So this is the difference between the highest weight that an individual has and their weight at presentation. So again, how much weight has been lost from that starting point. And we have multiple studies showing the clinical significance of weight suppression as an independent predictor of the severity of eating disorders and their outcomes. So this is irrespective of the presenting weight or BMI. So whether someone presents at a quote normal weight, a higher weight, or a low weight, we know that this weight suppression is an important factor. And then in terms of children and adolescents, we have a growth curve here. I'm sure many of you are familiar with this. We're not just looking for weight loss in these individuals, we're also looking for lack of weight gain or lack of height growth. So children who are dropping off their growth curve, that can be a marker of an eating disorder. And then lastly, again, to reiterate that eating disorder symptoms and behaviors can occur in individuals of any body size or shape. So we can't look at someone and know whether they might be engaging in behaviors. And we know that, again, these complications of malnutrition can occur no matter what the body size. So for atypical anorexia nervosa that we discussed a bit earlier, we know that the medical complications can be just as severe as in those with anorexia nervosa who are underweight. And then a bit about the medical assessment. So in terms of the vital signs, in addition to the routine vitals, we also check orthostatics. So that is blood pressure and heart rate lying down, sitting, and standing. And that's looking for drops in blood pressure or increases in heart rate with standing that can be caused by dehydration or malnutrition. And then in terms of checking height and weight, we recommend checking the weight in a gown. So this is really the most accurate way to check a weight and the best way to follow a trend. And also, just in case an individual might be trying to falsify their weight, it eliminates that as an issue. We also recommend checking the weight blindly, so having the patient step backwards onto the scale, or using a scale that has a screen that can be pulled away from the patient. And we're trying to encourage these folks to stop weighing themselves at home and really steer away from looking at those numbers and really let their healthcare providers focus on monitoring the weight from a medical standpoint. And then one last point is to think about trying to avoid documenting these individuals' weight on their after visit summary printout or on their patient portal, because seeing that number can be very triggering. And in terms of an exam, I'm not going to go through the details, but a thorough physical examination in a gown is indicated. There are many findings that we can see on exam in the setting of eating disorders. And so that thorough exam is very important. However, I would also note that some patients will have a completely normal exam and still be very sick. So we can't always see the signs when we examine them. And then in terms of further medical assessment, extensive laboratory testing is important, and this is guided by their behaviors or their diagnosis. But this is a list of some of the tests that we run. So blood counts, metabolic testing, multiple hormone levels, vitamin and mineral levels, and then urine testing. And one important point here is we recommend having the patient leave their urine sample first before they're weighed or have their exam, just in case they may be attempting to falsely increase their weight with what we call water loading, so drinking fluids before they come in for their visit. And then again, though there are many possible lab abnormalities, it's also important to note that many patients will have completely normal labs and still be very ill and in need of treatment. And this is true even in some severe cases of anorexia nervosa, because bodies really have an amazing ability to compensate in the setting of starvation. And then lastly, for medical assessment, these are some of the additional tests that may be ordered. Often an EKG is indicated to assess for cardiac complications or effects of medications. And then there are a few other tests that are indicated in certain situations. So an echo, which is an ultrasound of the heart, sometimes X-ray imaging to look for stress fractures, sometimes abdominal films are obtained depending on symptoms. And then a bone density test is very important in individuals with anorexia for more than 6 months. those who have been amenorrheic for more than 6 months, or those with low testosterone in men. So hypogonadism in men is an indication as well. Okay, so now we're going to move on to, I believe, our last section here.
Okay, so we're really just going to highlight a couple things because we realized that we want to make sure you have time for questions. So this is a set of do's. The overarching thing I think we want to highlight here is that kind of letting them know what are the symptoms, why they concern you, and then listening. I think those are really important do's. Excuse me. We have some don'ts here, and I just want to highlight the last two. One is not giving simple solutions like you just need to eat. Now, you may not do that, but in a moment of frustration, you may do that. We know definitely parents in moments of frustration do this. This is not going to be very productive. Excuse me. And then, sorry. Thank you. And then not making any appearance-based comments. So sometimes if someone with anorexia is starting to gain weight, people might say, oh, you're looking good, you're looking healthy. Don't call attention to weight and shape. We're trying to get them to not focus on that at all. All right.
Okay, so now we're going to touch just a bit on treatment options. So there are several levels of care for treatment of eating disorders, and so we'll give you an overview of these. So there's inpatient care, which is obviously hospital-based, and this is for the very medically acute patients who need frequent vital signs, might need very frequent labs, sometimes cardiac monitoring, and other interventions. There's residential treatment, which is 24-hour care, but for those who are less medically acute, who may not need, for instance, labs as often or as such intensive monitoring. There's partial hospitalization, which is typically a day treatment program, sometimes about 5 to 7 days a week, all day, and then the patient goes home in the evening. And there is intensive outpatient, which is usually 3 to 7 days a week, about 3 to 4 hours a day. And then lastly, outpatient. So this is when individuals will see each of their healthcare providers on their team about once a week or so. And so the American Psychiatric Association has very helpful guidelines. This is listed in our references, and there are links here that will help you determine what is an appropriate level of care based on medical assessment and based on symptoms and progress in treatment. And then, of course, it's important to note that the cost is very different for these different treatment options, and that there is variation in what insurance companies will cover. And so that can sometimes be a barrier. In terms of outpatient treatment, so the team approach is very important. So once you've diagnosed someone with an eating disorder, it's important to refer to outpatient specialists who have experience in the field of eating disorders. And so here's a list of who might be on an outpatient team: a psychotherapist, a registered dietitian, a primary care provider, and sometimes a psychiatrist. Just an overview of what the dietitian's role is on the team. So nutritional counseling often involves what we call meal plans with the use of food exchanges. And so this involves teaching patients approximate portions in different food categories, and it helps them avoid any discussion of or counting of calories, and also allows them choices within different food groups, but gives them enough structure to be sure that their food intake is adequate. Intuitive eating is something that usually comes later in treatment, after that initial phase of recovery as a patient is progressing in their treatment. And then the dietitian is sometimes helping with working on moderation and discontinuation of exercise if it's indicated.
In terms of psychotherapy, the main point is that there are therapies that have been shown to be effective. So that's something to be encouraged by and let your patients know. I'll just highlight a few things. Cognitive behavioral therapy, or CBT, there the idea is that our thoughts tend to drive how we feel and what we do, our actions. And so you really want to kind of identify those maladaptive thoughts that are making someone feel badly or making someone kind of engage in eating disorder behaviors. In terms of identifying and modifying behavioral patterns, that could be something like just walking through the day and the person says, well, I skip breakfast, I eat very little at lunch, and then the binge comes at dinner afterwards, saying, okay, part of what's going on besides mood and maybe other things is you're hungry. And so let's make sure you eat on a regular basis and make that behavioral change. For anorexia with adolescents and children, family-based therapy is what's most recommended. Parents and guardians deliver that treatment, and that's kind of guided by a psychologist. We don't currently have a treatment that is clear evidence supporting for adults with anorexia. There are things we do, but we do have something for bulimia, binge eating disorder, and youth with anorexia. And then there's some other ones that have been found support. And then just want to mention that group therapy is another alternative that can be very helpful.
Okay, and then just the last slide, I think, in this section. So the medical provider's role in the team is to evaluate and manage the medical complications of the eating disorder and to help assess the need for levels of care. And what I would say about this is, though the management of eating disorders may seem new or challenging to some of you, if you're not familiar with it, it's definitely within the scope of your practice. So it's within the scope of primary care providers to do this work, and know that you will typically have support from others on your team to help with other areas in the care of the patient. Pharmacotherapy, I won't go into great detail. There are limited medications that have been shown to be effective, but there is some data for SSRIs in bulimia nervosa and binge eating. And of note, SSRIs are ineffective in the setting of malnutrition or weight suppression, so ineffective or minimally effective. So they're often not used in that setting. But sometimes atypical antipsychotics are used in the inpatient setting to help with weight restoration and those with severe anorexia. And then, of course, there's treatment for comorbid psychiatric conditions. And then lastly, providing referrals. So there are resources out there. This website, findedhelp.com, or the NECA website can provide links to find treatment providers in your area. And then again, what's really important here is consistent communication. So communication between the team members and collaboration, which again is something that I find really enjoyable and an important part of this work.
Oh, and this is, we don't have time for this, but just want to highlight this for you. These are, we think, some interesting kind of snapshots about truths about eating disorders that dispel some of the myths. So we have 3 slides about those, and we'll just kind of encourage you to take a peek at those. And these are our references. And to wrap this up, questions. This is the National Center for Eating Disorder, Excellence in Eating Disorders email address, so feel free to ask questions via that way after the webinar. All right, thank you.
Great, that's it.
All right, great. Thank you very much, ladies. We do have a couple of questions in queue, and I do have someone that's raised their hand. Unfortunately, they don't have an audio connection for me to open up for them. So if you raised your hand and you still have a question, please chat that in using the question module on the right side of your screen in the webinar toolbox. So let's see here. The first question, why are patients with diabetes 1 at a higher risk for eating disorders?
That's a good question. So something we sometimes see is individuals who may either stop taking their insulin or use their insulin or use too much insulin, and it's a behavior that can lead to very serious complications, as you might imagine, either hyperglycemia or hypoglycemia, both of which are life-threatening. And so individuals may have fluctuations in their weight, may have an increase in body image distortion, and may be really at risk for that very dangerous complication.
Great. Okay. So what about medications that address the delusion that is occurring around body issues?
So medications. So again, there is some limited data for the use of some medications. So SSRIs, there is some data for use in the setting of bulimia, nervosa, and binge eating, mainly because it helps reduce compulsive thoughts and behaviors. So that is one medication that can be helpful. So that would be kind of the one category that I would say is helpful in certain areas. But again, there's minimal data for use of pharmacologic therapy for anorexia nervosa.
Yeah, and to add another thing to that, I thought the word delusion was really interesting, and you totally get it. And again, especially objectively, we'll say, no, that doesn't make sense. But I'll mention here that I think these, delusions are also very much fostered by our culture and our community. So in terms of what people, especially adolescents, see about what adolescent females, for example, what a woman should look like, often is much thinner than the vast majority of women out there. So I think really the better tack there is kind of a psychosocial approach, and therapy would be a way of doing that.
Definitely.
Can you explain a little bit the connection of hoarding with eating disorders?
Of hoarding?
Yes, hoarding, HOARDING.
Yes, that's actually, I don't know too much about that. So on the one hand, so this used to be kind of seen as part of OCD. It's separate, but I mentioned that because OCD is something that's often highly comorbid with eating disorders, with anorexia, I think in particular. I mean, according to the degree that, if it's food related, that could be in part of storing up for a subsequent binge. And certainly the secretive part that often is true of hoarding is very much in line with the experience of binge eating. But I don't know too much more about that.
Can you elaborate a little bit further on the definition of weight suppression?
Yes. So weight suppression refers to the difference between an individual's pre-morbid weight, so their starting weight, and then their weight at presentation. So typically, again, we're looking at how much weight has been lost by the time they present to be evaluated. And the reason why that's important is someone, like we mentioned, may come in at a quote normal weight or even a quote overweight or obese weight and have lost a significant amount of weight and be very sick and malnourished. And whereas if we were only looking at their presenting BMI or whether they were underweight, we might miss the fact that that person is at significant medical risk. So it's looking at the decrease in weight rather than necessarily just the absolute weight.
What percentage of patients who present with gastric bypass surgery have eating disorders?
That is a very good question. I don't know the statistics on that, so I will not be able to quote you a number, although the numbers are high. Individuals who seek gastric bypass surgery do have a higher rate of eating disorders, and disordered eating can begin or change or morph into something different after the surgery. That's something we could probably look up maybe the data for and send that out if that's helpful. But it is really important that individuals are screened for eating disorders before moving forward with gastric bypass.
Can you address orthorexia nervosa?
Can you repeat that?
Yeah, they're just want a little information around orthorexia nervosa.
Orthorexia.
Or they're super healthy.
Right. Orthorexia, yes. So that refers to sort of an extreme version of eating in a quote healthy way. So restriction in variety of foods or choosing foods that they believe to be quote healthy, that may be their guiding principle, is this extreme restriction in variety, aiming for this sort of quote healthy lifestyle, being kind of the driving force. And that is certainly something that's fairly common in our society today, given some of the societal pressures and things that we see and read about certain foods that might be quote good or bad for us.
And it doesn't currently fit under any eating disorder diagnosis, but one thing that I'm always struck by with orthorexia is, so there's a rigidity often there and a heightened preoccupation about food, which we do see especially with anorexia. And so I think for some people, I don't know if there's been research on this, can that be for some people an entry point into subsequent anorexia? It seems likely that it could be. It clearly doesn't determine that. But yeah, so not considered eating disorder, but certainly has some commonalities that would be concerning and you would think might negatively influence kind of psychosocial functioning.
Yeah, I think that's an important point to note that could be a sign that someone may be on their way to developing a diagnosable eating disorder.
So several years ago, there was data that indicated that asking directly about an eating disorder might drive an anorexic away, but would not drive a bulimic away. Do you know if this data has changed?
I don't know if this data has changed, but a couple of comments. One is if there are concerns about that, that is for also like the NECA screener could be really helpful, if they would maybe be more open in that sort of setting. So we talk about anorexia nervosa as being egosyntonic and bulimia nervosa as being ego-dystonic. So something that's ego-syntonic is like, so anorexia is ego-syntonic in the sense that individuals with anorexia often value being thin and feeling in control of their weight, and guess what? that's what anorexia does for them. It helps them give a sense of control. They're thin. And so why would I change? And so if you're asking me these questions, I maybe not as forthcoming, potentially. And that's at least also mentioned with the ambivalence, or maybe I'm kind of wanting to change because, my parents are policing my every, meal, and I'm not being able to go out with my friends, but I'm also really scared that this is going to be taken away from me, this sense of control. Ego dystonic is that it doesn't align. So people with bulimia nervosa typically do not want to be binge eating. They do not want to be vomiting. They do not want, and so they are often more open to share and disclose. So that's maybe where that's coming from, but I don't know if there's a change in the findings and the data there.
Okay, so thank you for that. We do have a couple of questions left in queue, but we are at time. So please, if you submitted a question and we have not presented it yet, we will follow up with you via email after our session today. So please be on the lookout for that. I do want to remind folks that this was the first webinar in a 4-part series. So our second webinar is on February 6th at 1 p.m. and that's the role of primary care in treating eating disorders. And so we do want to thank you all for participating in our session today. Please know that there is a brief evaluation when you exit the session. We do ask that you take just a couple of minutes to submit your feedback. We would love to see your responses and maybe drive some change in the future webinars in the series if needed. And lastly, we do want to thank our presenters today for sharing this valuable information with our members. We really appreciate your time, ladies, and for sharing your expertise with our members. Definitely appreciate it here on behalf of CPCA. And with that, just really quick, today's session was recorded. We will send a follow-up email with a link to the recording, and we will again attach the materials and any of the links that were included in the presentation. And so you can look for that later this afternoon. But with that, again, thank you, ladies, and thank you, everyone. Have a wonderful afternoon.
Thank you so much for having us.
Take care.
Appreciate it.
All right, take care.